Hello, everybody. It's a pleasure to be here with you, uh, sharing this theme about a state of the art in the assessment of infertile men, what you need to know. I am Jorge Rincón, urologist. As you know, male infertility is the an inability of sexually active, non-contraceptive couple to achieve spontaneous pregnancy within a year. This could happen in about 15% of the couples. It is called primary infertility when there is no uh, pregnant before, and it happens in about 1 in 8 couples. Secondary infertility is when the couple has previously had a child with the same partner or with another partner, and could happen in 1 in 6 couples. Male factor is present in about 50% of the cases, so it is mandatory to perform a study of male fertility in every infertile couple. It is called idiopathic male infertility when there is everything normal, included history, medical examination, even endocrine, lab tests, imaging tests, but there is any analysis of the semen with pathological findings. And this could happen in about 30 to 40% of the patients. Unexplained infertility that occurs in 20 to 30% of the patients is when everything is normal in both members of the couples, but there is no pregnancy. This could happen because of endocrine disruption, like pollution, free radicals, sperm DNA damage, or could be problems of genetic or epigenetic abnormality. Male infertility could impact on self-esteem, mental health, financial status, or marriage. And the main goals of the study of the male infertility is to know what could be the possible etiology and to know if this cause is reversible, like a varicocele, or if it is irreversible and needs an RT like insemination or IVF or ICSI, or if the problem of fertility is severe, we could recommend adoption or even donor sperm. Also, it is important to give advice and counseling to the couple in order to see if there is any risk of transmitting any disease to the offspring. And uh, infertility sometimes is associated with life-threatening conditions like cancer, immune problems, cardiovascular disease, and could increase the overall mortality. So it is important to know what could happen, what could produce the infertility in order to advise and to give counseling to the male patient too. Advanced paternal age is one of the main causes of infertility nowadays. When we perform a study of a male, we must have in mind the maternal age, because the age and the ovarian reserve is important to understand what could happen in the couple and to realize if we need a more aggressive treatment in order to be succeed with the pregnancy of this couple. The main causes of male infertility are sperm production problems like chromosomal or genetic causes, undescended testes, testicular torsion, varicocele, or radiation damage. There could be a blockage of sperm transport, like in infection, prostate-related problems, absence of bad deferens, or vasectomy. There could be any sexual problem, like problems with ejaculation, erectile dysfunction, infrequent intercourse, spinal cord injury, prostate surgery, damage to nerves, or some medicines. There could be hormonal problems like in pituitary tumors, congenital lack of LH or FSH, or with the abuse of anabolic or steroid medication. And finally, there could be sperm antibiotics, in vasectomy when there is an injury or trauma of the testicles or unknown cause. Here, there is a meta-analysis of more than 10,000 patients. And in this table, they explain us the main causes of infertility in the male. We must begin the study of a male infertility with a medical and reproductive history. Then we must follow with a physical examination. And finally, we must perform a semen analysis following the WHO guidelines. After that, if it is necessary, we could perform another test like sperm DNA fragmentation, hormonal determination, genetic testing, or imaging. In medical history, we must know about the lifestyle of the male, the reproductive history, the sexual history, family history, if there is any presence of comorbidity like hypertension, diabetes, obesity, or testicular cancer. We must rule out any infection of the genitourinary tract like STD, if there is any surgery in testicular area or in abdominal structures, of if there is any testicular torsion or trauma before. We must know about the use of gonadotoxins like chemotherapeutic agents or anabolic medications. We must see if the patient has been irradiated or exposed to cytotoxic agents. We must know about congenital pathologies, heat exposure, and varicose. The medical examination is compulsory, and we must look for secondary sexual characteristics, the size, texture, and consistency of the testes. The volume, the normal volume of the testicles is about 15 milliliters. We must palpate the vas deferens, the epididymis, and rule out if there is any varicose. We must look for penis abnormalities like phimosis, fibrotic nodules, epispadias or hypospadias. And finally, we must look for gynecomastia. Semen analysis must be performed under the guidelines of the WHO Laboratory Manual for the Examination and Processing of Human Semen. And these are the normal values. If the first spermogram is normal, we don't need to use more spermograms. But if there is any abnormality, we must perform at least 2 spermograms in order to see what's going on in there. When we see the semen analysis, we could find oligospermia. That means that there is less than 50 million of spermatozoids per milliliter. Or we could find astenospermia. That means that the progressive motile spermatozoids are under 32%. Or we could find teratospermia. That means that the normal forms are under 4%. It is common to find abnormalities in different aspects of the sperm test, and this is called oligoastenoteratospermia. Finally, azoospermia means that there is no spermatozoids in the sperm test. In that case, we must perform a centrifugation test in order to see if there is any spermatozoids in the sediment, in order to avoid an unnecessary surgery and to recover those spermatozoids in order to perform an IC test, an IC insemination. When we have impaired embryo development, miscarriage, recurrent pregnancy loss, of birth defects, we must measure sperm DNA fragmentation, because sperm DNA fragmentation has been shown to reduce natural and ORT conception. The normal value must be below 25%. The sperm DNA fragmentation could be high in hormonal anomalies, varicocele, chronic infection, and smoking. Sperm DNA fragmentation is low in testicular sperm when compared to ejaculated sperm. When we find a sperm count below 10 million per milliliter, we must perform a hormonal determination. Or when we find features on physical examination suggestive of endocrine dysfunction, we must perform initially FSH and testosterone, total testosterone. And if these hormones are abnormal, we must measure LH and prolactin. In the same way, genetic testing must be performed when the sperm count is below 10 million per milliliter. And this is very important in order to give counseling to the couple and to see if there is any risk of transmitting any disease to the offspring. Also, we must perform a karyotype when there is a family history of miscarriages, malformations, of mental retardation. The chromosomal abnormalities could be numerical, structural, sex chromosome abnormalities like in Klinefelter syndrome, could be autosomal abnormalities like in Prader-Willi syndrome or Noonan syndrome, or maybe cyst fibrosis gene mutations. When we find in the examination of the patient an absence or abnormality of the vas deferens, we must see if this problem is unilateral or bilateral. If we always have to perform a renal ultrasound, and when there is unilateral absence of the vas deferens, and if this is found, we don't have to measure the CFTR screening test, because the majority of the patients are usually fertile, and this could be only an incidental finding during vasectomy. When there is unilateral absence or abnormality of the vas deferens, but there is no renal abnormalities, we must perform a CFTR screening. Also, when the absence of the vas deferens are bilateral, we must perform CFTR screening. Y microdeletion must be performed when there is a count below 5 millions per milliliter. A recent study has found that the alterations in Y microdeletion is mainly found when the count of spermatozoids are below 1 million per milliliter. This abnormality is present in about 8 to 12% of the azoospermic men, and it could be found in 3 to 7% of oligospermic men. In these Y microdeletions, ACFC deletion are most common and is present in about 65 to 70% of the patient. The couple must be counseled about the risk that all male offsprings will inherit the deletion, and sperm can be found in 50 to 70%, 75% when we perform a testicular biopsy. ACFA and ACB Y microdeletion are associated with severe spermatogenic problems, and TESE or testicular biopsy is not recommended. We must perform an scrotal ultrasound in order to measure the testicular volume. We must see the testicular anatomy and structure and see if there is non-homogeneous and microcalcification in the parenchyma. We must look for indirect signs of obstruction like epididymal ectasia or epididymal absence. we must roll out and we must find varicocele in the ultrasound and testicular cancer. Transrectal ultrasound is performed when obstruction is suspected, and this could happen when low seminal volume is fine, when there is acidic pH, or severe oligospermia or azoospermia. And in those cases, we could find ejaculatory duct cyst, or seminal vesicular dilatation, or hypoplasia. Finally, this is a nomogram that we must follow in order to study an infertile couple. Thank you very much for your attention. It's been a pleasure for me. Bye.